and it is preparing. Give me 1 second.
It's water.
All right. And we are live online right now. Good. Pull up this here. Change the view. Oh, sorry. You're also hearing me right now. There we go. All right. Here we go. All right. Thank you, everybody, for joining us today. We're very excited for our Ask the Hematologist. Why don't we just go through and introduce ourselves? I'll start with me first because I realized I haven't been doing this in the past, and then I got some questions about who I was. My name is Claire Martin, and I am the Director of Operations for the USTMA. So whoever wants to go next can.
All right.
Hi, I am Dr. Camila Masias, and I'm a hematologist in Miami, Florida. And my area of research and clinical interest is patients with TTP and atypical HUS.
Go ahead, Eric.
I'm Aaron Metjian. I'm a hematologist at the University of Colorado in Denver. And like everyone else here, very active clinical and research interest in TTP.
I'm Spirit Cataland. I'm at Ohio State University and clinical and research interest in TTP, and happy to be here tonight with everybody and this esteemed group of colleagues who are dressed better than I am today.
All right, so we'll go ahead and just jump right into one of the most popular topics we've been getting asked is, are the COVID vaccines causing TTP or any other TMA related disease? And if so, should TTP patients still get the COVID vaccine?
So I think, to my knowledge, there's been some case reports of patients that had an acute event of TTP after a period of time after receiving the COVID vaccine. However, I think there's been 3 cases reported so far. Feel free to jump in if I'm wrong, but in any case, I think that what's important to notice is that having acute COVID, having that COVID infection can certainly trigger not only a TTP episode, but all sort of platelet complications, low platelet, and bleeding and clotting at the same time. So I think that when we look at the risk and benefits of getting the vaccine and the very minimal risk of potentially triggering a TTP episode versus getting the infection, certainly the risk of not getting the vaccine are very high. Obviously, this needs to be discussed with your hematologist to make sure that your labs are normal, but I encourage all my patients with TTP to get the vaccine so that they don't get COVID and prevent a myriad of other medical problems.
I agree. Anything you're going to get from the vaccine is going to be far more likely with COVID. We are learning, as Dr. Masias said, there are some case reports of TTP developing after the vaccine. And it might be similar to our patient who we're just in the process of publishing, who had a history of TTP, had undetectable atom TS13 activity, and got her vaccine. And in her case, it triggered a relapse of her disease. So what we think it might be is somebody who might be predisposed to getting TTP. They may have undetectable atom TS13 activity, but don't know it. And that vaccine kind of flips them over into an acute episode. So all of our patients are getting vaccinated. We're now using some caution. Anybody who is less than 20% of the atom TS13 activity, we're giving it some more thought. We're talking about treatment to improve that. In the case of our patient, she actually already had Rituximab and didn't respond to it, but was doing fine in remission. And this vaccine sort of kicked her into an acute episode. So all should get it with some caution.
I mean, I'd like to reiterate that is that for all my TTP patients, I recommend COVID vaccines. I mean, it should be noted that there are over 7 billion doses have been given of the COVID-19 vaccines of all the different forms. And inevitably, we know that we are going to see someone who will get a COVID vaccine and may relapse with their TTP, or they may develop TTP. But whether or not those are causal or just simply associated, and I think that's probably the best way to look at it. And I think, as Dr. Cataland said, the risk of getting COVID is far worse than than any of the risks from the vaccinations.
Yeah, and I want to also add that I think there are some things that we're still learning about COVID, but there's some other things that we know now. We know a lot. And I think that by now, this is not a new vaccine anymore. I mean, billions of people have received it and done really well. And it certainly prevents mortality from the disease.
I agree.
And would you guys recommend one vaccine over the other, a certain type of vaccine, or is it whatever you can get is best?
Whatever gets to your arm is the best vaccine you can have. And I think that, I don't know if there's people from other countries watching us tonight, but here in the United States, you can get any vaccine. You can take your pick and, go to any random pharmacy in the corner of wherever you live pretty much and get a vaccine. But other countries are not so lucky. So whatever vaccine is available to you, it's the best vaccine. I think that we've discussed before, there's been some, again, case reports that have not necessarily been associated with the vaccine, but we've seen some number of case reports of thrombosis with the Johnson & Johnson vaccine. We're still, that there has not been established a sort of a causal relationship. So we don't know for sure if the Johnson & Johnson vaccine causes thrombosis, but there's some case reports. And so if that's a concern for you, you can do the mRNA vaccines, either Pfizer or Moderna, but any vaccine is the best vaccine.
Yep, I would agree. I think what you're referring to is this rare this vaccine-induced thrombosis and thrombosis, and that's exceedingly rare. It's been seen with the Johnson & Johnson, but that's different than people talk about venous thrombosis in the legs or in the lungs. That's a different animal. And I don't think the vaccines, you guys correct me if I'm wrong, have been associated with an increased risk for blood clots in the veins. I think there's been the COVID caused an increased risk for thrombosis, and that's kind of been extrapolated into the vaccines. But I think COVID causes thrombosis, venous thrombosis. I don't think the vaccines have been clearly shown to do that.
No, as I said, I think there was a concern with the Johnson & Johnson vaccine different from the thrombosis and thrombocytopenia, but again, no causal relation.
Any vaccine with common sense and a mask in the bad situations is what you need.
All right. Here we have a question about Adams TS13. And does somebody just want to give a quick overview on what Adams TS13 is so that everybody here is on the same page? Just a quick, brief overview.
Go for it, Eric.
Let me know if I keep going on too long.
You're good.
I mean, we'll just mute you if you do, so it's all right.
Claire has the ultimate power here.
I mean, in order to talk about Adams TS13, I really think you also need to talk about von Willebrand factor, because the two kind of they have to go hand in hand. But you can think, let me start off first by explaining von Willebrand factor. You know, I tell my patients, think of it as like it's the biggest protein that circulates in our plasma, in our blood. And think of it like a roll of duct tape. It's there to spackle up. It's there to seal up holes in the plumbing. And when this big roll of sticky protein is being made, there is a molecular scissor called Adam TS13 that sits there and just snips it into these appropriate sizes. If that Adam TS13 activity is too much, that flypaper, that duct tape that the body is using to spackle up the holes cleaves into these little pieces. And it's like trying to patch up a hole with Post-it notes. Alternatively, if that Adam TS13 activity, if that Adam TS13 is gone, then that von Willebrand factor just gets bigger and bigger and bigger and bigger and bigger. And the way I explain it to my patients is like, think of it like that cartoon of that suitcase that's just packed to the gills, where the pant leg, the shirt sleeve, the sock is sticking out. And then all of a sudden that von Willebrand factor, instead of being nice and compacted, just opens up. And when it opens up, this big, super sticky protein is now floating through the body, sticking to platelets, sticking to other platelets, sticking to other von Willebrand factors. And it causes this three-dimensional glop, this to just float through the arteries. And that's what causes the thrombotic microangiopathy. So ADAMTS13 is what is needed in its absence. The only thing that we know that it does is it snips von Willebrand factor into the appropriate sizes. And without it, you get this ultra large, pathogenic, huge molecule of von Willebrand factor that gums up the works. Hope that answered the question.
Yep, that's good. So the question is, the patient was diagnosed with TTP, but they had never been deficient in ADAMTS13. So is it required to be deficient in ADAMTS13 for a TTP diagnosis, or are there special cases where you're not ADAMTS13 deficient?
The slam dunk is if you have a level that's less than 10%, whether that's congenital or immune, but that is TTP. We know that there are rare cases where people have presented initially with lower levels, like around 30–40%, and then they're checked again and it's now below normal. But I would, not knowing all the details, if someone had an ADAMTS13 level that was, let's say, higher than 50%, let's say, I would question the diagnosis of TTP.
Yeah, I think what they might be referring to is TTP is really defined. It's the diagnosis is confirmed by their slow ADAMTS13 activity. There are other things that look like TTP, low platelet count, these schistocytes. We now call those TMAs. So TTP is under the category of TMA, and it really is related to that low ADAMTS13 activity. It gets a little complicated from there.
Yeah, I was gonna say we like to make very complicated acronyms, and TMA stands for thrombotic microangiopathies, and
Thank you.
Involves a group of diseases that have a similar clinical presentation, but really TTP by definition is a deficient ADAMTS13, a severely deficient ADAMTS13.
Okay. So here's kind of an interesting talking point. This person's son was diagnosed with congenital TTP only after having COVID. Now, could you speak to why the COVID infection may have brought out the diagnosis of congenital TTP?
Yeah, I mean, remember this, we talk about this disease being the acquired type, the immune mediated is an antibody is developed that clears the ADAMTS13 or blocks its function. So you could have somebody who develops an antibody from COVID that then causes a low ADAMTS13 activity and then can trigger a relapse. They also may have undetected low activity and the infection from COVID triggers an acute TTP episode. It's certainly possible. And one thing we have to remember, we talk about low ADAMTS13 activity and getting TTP and being at risk for relapse. But there are also people who don't have low levels of they don't have that ADAMTS13 activity, both acquired, this immune mediated, and also they're born without it, and yet don't get in trouble until later in life. So just a low activity by itself puts you at risk for problems, but it doesn't absolutely give you a problem.
Okay. So the idea is that the COVID vaccine or the COVID virus highlighted the deficiency of ADAMTS13, not necessarily caused it.
Sort of brings it, we call it the second hit. So it's that low activity and then this inflammation from COVID led to sort of the overt TTP event in somebody who may have already been at risk for it.
Gotcha.
It also can create the antibody and the second hit. We just don't know because we just don't know what somebody looked like a week before they got COVID.
Gotcha. Dr. Masias, this is one you might be interested in. This is a 36-year-old pregnant female with a history of TTP, 28 weeks gestational age, and currently her Adams TS13 is at undetectable levels when it was normal earlier in pregnancy. What would you do to help monitor the pregnancy? Would you recommend Rituximab, plasma exchange? Would you do steroids? What is current guidance?
Sure. And so this is a lady who is pregnant with a history of TTP.
Yes.
And has a deficient Adams TS13 activity in her second trimester, but not has TTP right now, right? Not has.
Correct.
Yeah. So this is a topic of interest of mine and Dr. Anna Anton, who works at Emory, and we're working together to trying to get some answers to questions like these. And we know that, as Dr. Cataland was saying, when patients have a diagnosis of TTP, they need what we call a second hit, something else. They can live their life with a deficient, sometimes deficient Adams TS13 activity, and they do just fine. But some patients, when they're under some kind of stress, namely pregnancy, a viral infection, then that situation triggers a TTP episode. So how can we prevent a TTP episode during pregnancy and the early postpartum period, which is also very concerning? One of the ideas is, can we, ideally, in the ideal world, we would like to keep the Adams TS13 activity normal through pregnancy so that we are rest assured that the patient will do well. And there's a couple of things that we can do to achieve that. And one discussion has been the use of Rituximab during pregnancy. Rituximab is officially not approved for their use is not approved during pregnancy. However, we've used it in some patients and we've been successful at raising the Adams TS13 activity without having any consequences for both the mother and the baby. And we are actually looking into more depth in our United States TMA registry to see if other sites have used it and we can show our experience with it. But that's a possibility. Another drug that we've used successfully is called Cyclosporine, that it's taken also through pregnancy to achieve high levels. And then the other possibility is to have a close monitoring of the Adams TS13 activity, but also the platelet count and other markers of hemolysis that we use to sort of either detect a relapse earlier or prevent it.
Very good. So for just normal patients, how often would you recommend, non-pregnant patients, how often would you recommend monitoring the Adams TS13? Or what do you guys do as far as follow-up in your clinic?
Usually when we have a patient that has a new diagnosis of TTP and is doing well, we discharge him or her of the hospital. We see them weekly for the first month, and then monthly for the first couple of months, and then every 3 to 6 months, honestly, indefinitely, because we want to make sure that we're on top of two things that we are seeing in patients with TTP. One is we know that about 40% of patients with TTP will have a relapse, and this can occur most commonly in the first year after diagnosis, but can occur at any point in their life. So we monitor them for that, and then the other thing is that we are seeing that patients with TTP have a variety of long-term complications that we want to make sure we stay on top of it.
Okay. And so when you're monitoring the Adams TS13, at what level would you guys prophylactically treat, and what would you use to prophylactically treat?
I think I'll go with that one. The easy answer is if we see a level of less than 10%. I think everyone here would say that's a slam dunk. There's really, for us to be no real question that it represents sort of an immunologic relapse. It's a little tougher because we do, using the data from the French thrombotic microangiopathy centers, what they've shown is that when you see someone's Adams TS13 levels start to drop, they've sort of pioneered the use of preemptive Rituximab as a way to sort of get those Adams TS13 levels up. And I think for me, and I'll see I'm interested in what everyone else thinks. I think once I see it drop to less than 50%, that's when I pull that trigger. I have noticed that there are times when I'll see a dip from 90% to 70, and maybe around 55%, and then we hold our horses and it comes back. But less than 50 is sort of, for me, my line in the sand.
Yeah, it's kind of it's how it's evolved over time. Like Era said, it used to be 10%. Now it's kind of moved to 20%. We also know you can't, it can be variable. So we like to use the trend more than just one number. So what will get our attention is somebody going from 60, 40, 30. Someone trending down, we'll think about doing it. Now, interesting, we've never had any trouble before. Insurance companies are now holding us to this 20% threshold, which I don't agree with. But that's what we're dealing with. So certainly trending down close to 20 in the direction of 20 on multiple values gets our attention and puts you in a situation where the benefit of doing it outweighs the small risk associated with it. What about you, Camilla? What do you do?
Yeah, I would say that as every patient is different, and it's important to look at the trend of each patient. But we see a decline reaching 20 to 30%. Yes, we would agree.
Okay. And would you guys always use Rituximab, or would you use something else first?
Well, we were biased at first at Ohio State. We did some studies with Cyclosporine, and it does seem to work, but it doesn't seem to work beyond after you stop taking it. So Rituximab, I think, is just easier. It probably has less side effects, I think, and been shown to be more effective. So it's nice that a 3 to 4 week, typically 4-week course we do, seems to last patients 1.5 to 3.5 years. Average is probably maybe around 20 months, close to 2 years. But it seems to work long after you give the treatment, so it's more functional and practical for patients.
Gotcha. And have you guys seen side effects with Rituxan? Anything like any infusion reactions or issues with memory or shaking or illness or anything like that? Or what side effects have you seen with Rituximab?
Really, nothing that you've mentioned. I think there's a couple of things to consider when we think about giving a patient Rituximab. One is we check for a hepatitis B infection or prior exposure to hepatitis. And if that test comes back positive, we may give the patient a pill to prevent reactivation of hepatitis while they get Rituximab. And then in this pandemic era, we worry that patients that are receiving Rituximab are at a high risk of developing COVID, and they also may not respond, not get, I guess, the same response to a vaccine if they just receive Rituximab. So it's important to time it in accordance with, I guess probably right now I would favor getting the vaccine first and then administering the Rituximab. But it depends on where you live. But those are the things to consider. Short term, while the patient is receiving the infusion, I guess as with any other medication, there's a risk for an allergic reaction. But the patients are closely monitored, and I haven't seen any, honestly.
Yeah, I think there were some concerns several years ago for infection risk. They just really haven't borne out. We do see reactions. It's pretty normal during your first infusion to react to it in the infusion center, but stopping the infusion temporarily, giving either steroids or Benadryl can help with those symptoms, and people tend to get through without too much trouble. And number 2, 3, and 4 tend to not have the same reaction. So there is an infusion reaction with it, but it's nothing horrible for most patients.
Okay. And this person had a medication called Ruxinence, I think, Ruxinence. I'm not familiar with it.
Ruxolitinib?
Yeah.
Maybe. Are you guys familiar with that? Have you utilized it for TTP patients?
No. Is
that Jacophy?
Yeah. I mean, Jacophy's ruxolitinib. Ruxience.
It may be a different name. There are a lot of names that are biosimilars, meaning generic for Rituximab.
Yeah, absolutely. Yes, it's a biosimilar for Rituximab.
Okay.
Oh, for Rituximab. Okay.
Yeah.
Okay. Yeah, and they say they really struggled with it, and so there we go. Yeah, it's a biosimilar. they said they really struggled with it, and if we knew why that there might be a difference there, or if you had heard that there was an issue with it over rituximab.
No, I think many patients are being pushed to that choice by their insurance provider because the biosimilar is cheaper. So would I tell a patient not to get a biosimilar to Rituximab if they needed to be treated? No, I would tell them to still get it.
Okay. So switching back to congenital TTP, if a patient is currently on coate, would you ever take them off coate? And if so, at what point would you consider them stable? How would you monitor them to determine if you needed to restart some sort of therapy for them?
It's just sort of two types of congenital TTP patients. One that seem to have ongoing problems routinely and regularly with a lower platelet count, maybe clotting issues, other symptoms, neurologic symptoms. Those are the ones that tend to get on ongoing treatment. There are other patients who have higher levels of ADAMTS13 that might be 4, 5, 6, 10%, and may only get in trouble episodically or after an infection during pregnancy and things like that. So it's sort of hard to answer that question over a forum such as this, but it's a sort of a discussion with your doctor to see if there are ongoing issues that need to be prevented. That's when the coate or the plasma ongoing every 2 weeks in general makes the most sense. If it's more episodic, then it's just episodic as needed treatment. So it's just hard to know where that patient sort of fits on that spectrum.
Okay. But it is possible for certain congenital TTP patients to not need constant treatment, could just need monitoring. Okay.
Certainly.
Okay. So this patient's asking, do you know if there's clinical research? Do they know if there's clinical research, if there's an ADAMTS13 in pill form that will open again soon, and will there be any openings in Florida? My husband has congenital TTP and has allergic reactions to plasma transfusions like every week he receives them, so we're hoping a pill form would help. Now, I know there's recombinant ADAMTS13, but I don't believe that's a pill, correct?
Correct.
Yeah, that's not a pill.
Yeah. So do you guys want to explain what the recombinant ADAMTS13 is and how it would be utilized for both acquired and congenital patients?
So as we were saying, I think for the diagnosis or the definition of TTP, you have to have deficient ADAMTS13. Either if you have the acquired form, then you'll have your ADAMTS13 is going to be deficient because you have auto antibodies. You're sort of attacking your own enzyme. And the congenital form, you just don't have the amount, you don't have antibodies against it. And recombinant ADAMTS13 is essentially synthesized ADAMTS13 that for the patients with congenital TTP, I guess is going to function as they were getting plasma infusions and they were getting the ADAMTS13. So this is another way of receiving the same ADAMTS13. And it is an injection as we're discussing. And I don't know, there's clinical trials going on right now for both forms of the disease. But I'm not quite sure when will it be available.
Okay.
One thing though, if for the patient that with a congenital TTP that's having problems with plasma, the possibility could be, I don't know if it was mentioned, Claire, but like coate is, or those, low or intermediate purity factor VIII, of which coate is reportedly the highest amount of ADAMTS13. That could be a possibility while they're waiting for the recombinant ADAMTS13 to come out.
Okay, so they would have other options since they're having allergic reactions.
Yes.
Okay. Here's an interesting, another interesting topic. So 46 or 47-year-old male was diagnosed with TTP, tried all sorts of procedures in the hospital, was there for an extensively long time, almost a year, as they stated. The very last resort was to remove their spleen. Worked, they haven't had any relapses. How often would you recommend someone being monitored if they have splenectomy? Would it be any different than a normal patient? And just in general, what amount of patients will relapse and what amount won't? So what percentage? And are there risk factors that make you more likely or less likely?
Whole bunch of them there.
Yeah.
Yeah.
So who wants to talk about splenectomy first?
I'll
Maybe
do
explain why it's a treatment and how it's effective.
Well, go ahead,
Go
Camilla.
ahead. No, you go ahead.
No, I mean, it's an older treatment. It used to be the only treatment for TTP. And it might work in some patients because it removes a large site of antibody production is the idea. I think the thinking now is that it may be an effective, it's being revisited now, it might be an effective treatment for preventing relapses of TTP. But in terms of treating an acute TTP episode, the studies that are out there show that it's pretty dangerous. And those studies were before we had Cataland, which can usually get people out of an acute TTP episode. So doing it up front is a bad idea in general, but it may have a role in the future of preventing future relapses.
I would say that the role of the splenectomy, that the reason why it works or we used to use it, do it in patients with TTP is because it's gonna, the spleen is sort of making these antibodies against the ADAMTS13, and so when you remove the spleen, then you stop the antibody production, and then that's why the ADAMTS13 goes up, and you not only treat the disease, but are hopefully not have more episodes in the future. But I agree with what Dr. Cataland just said. I think this is not a treatment that we use, I don't think at all anymore, when a patient is having an acute episode of the disease. Once a patient has recovered and we're worried about him or her having a relapse, and maybe he's tried Rituximab and many other lines of therapy and he's still relapsing despite all that, then we've used splenectomies and as a preemptive therapy. So you want to look at that in the same way.
And sorry.
No, that's okay.
I would also, one thing just along that line, splenectomy is something that we've done a lot more for a somewhat related disease called ITP. And I would say, like, just now that the spleen has been taken out, one of the things just to keep in mind is that that patient should have gotten immunizations beforehand. And there's a schedule list of those immunizations that need to be kept up with afterwards. Just a little plug out there.
Yep.
Okay. And would you follow a patient who had splenectomy any differently than you would any other TTP patient? Do they need more frequent or less frequent?
You know, the vaccines, as Era mentioned, are very important. And there was a very collection of post-splenectomy vaccines patients should be getting: pneumococcal, meningitis, what's called H influenza. But the follow-up for a future relapse really is the same as any TTP patient. And I think the question also was asked, what's the risk of relapse? And I think most people, an average number is 40 to 50% of patients will relapse. But it's unpredictable. You can go 10 years not have a problem and develop a relapse. So in general, half might relapse. The factors that are important for relapse seem to be low ADAMTS13 activity, less than 10%. Younger age seems to be an increased risk for relapse. But a lot of the work that many of us are doing is trying to better refine some predictive models to see who's at greater risk for relapse. So who needs regular Rituximab, and maybe who you don't have to treat, who you can just watch without it. And hopefully more coming out on that in the next year or so, if not sooner.
Great. That is good. Let me see here. Okay, and how soon would a patient see the effects of Rituximab? So how quickly would the benefits of the regimen be? Would it be after the first dose? Would they have to wait after the fourth dose? Would it be a good acute treatment, or what would be the benefit there?
I think one of the things to keep in mind is that even if we were able to turn off all of the autoantibody production, the inhibitor to ADAMTS13, it's still like that class of molecule called IgG has a half-life of about 4 weeks. So we wouldn't expect it to just all of a sudden, the ADAMTS13 level to all of a sudden, I'm sorry, the inhibitor to all of a sudden go away. So it could, I tell my patients you can consider to take it up to 4 weeks for this to actually take effect.
Yep, I agree. I think you look at Marie Scully, one of our colleagues from London, who studied this, and you really didn't even start to see an improvement until about 10 or 14 days. So you really have to give it at least 2 and probably closer to 4 weeks to say, is it being effective? And that's why rituximab is really helpful for long-term preventing relapse. It's not so helpful in shortening the upfront course.
Okay. And now for some of the long-term impacts that you're seeing of patients who have survived acute episodes. So patients have brought up things like headaches or short-term memory loss. Have you guys seen anything that's been effective in helping either prevent these or lessen the impact of them?
Unfortunately not. At this point, I mean, we're at the earliest stages now. I think a couple of years ago, it was just a few people understood these complications. Now more experts in the field and doctors understand they can occur. But we're just finishing a study in the USTMA now, trying to understand how common they are. We don't know why they happen, so it's hard to know how to prevent them if we don't know why they're occurring. Might be related to low ADAMTS13 activity, but it's also likely not just going to be that. There's going to be other things involved as well. So a lot of work that has to be done in that area in particular, especially since more and more people are now surviving and living longer with TTP. So it's going to be an important area of research, and it is right now.
Yeah. So in an emergent situation with a patient who is pregnant, and let's say her platelets drop, has a low ADAMTS13, would you recommend a research regimen, or is that just more up to whatever the OBGYN feels comfortable with? Because obviously these people will be monitored with a high risk OBGYN.
I think I'm not sure what there's not a whole lot of research trials. Unfortunately, pregnancy sort of eliminates a vast majority of patients who are pregnant, just because that's an added risk. I would say, at the very least, what we know is if a patient is pregnant and relapses with TTP, plasma exchange is, I would have zero qualms. I would not consider that remotely to be research. I would recommend that highly. Whether, we know steroids can be used with TTP, the treatment of TTP in pregnancy. As Dr. Masias said, there is concern about the use of Rituximab, but it has been given safely in patients who are pregnant. The biggest question, the can of worms I'm going to open up for my panelists, is whether or not the use of Cataland can be used. Some people have written that it is not indicated because of the risk of the effect on the fetus. But there is a case report out of Germany where this was used in a patient who was pregnant, and it was felt to be very successful, particularly for that person who was not responding to sort of traditional therapies. So yeah, it's Linus. I think it's Linus Volker's group. Who put that one out there. But it's, my 2 cents is that TTP is potentially life-threatening as it is, and in the setting of pregnancy, my 2 cents is I would advocate for rather aggressive therapy, just because the stakes, in my opinion, my belief is that the stakes are that much higher. A healthy mom is a healthy baby, sick mom is a sick baby, and a dead mom is a dead baby.
Yep, I agree. I mean, certainly routinely to be used in pregnancy, you probably won't get there. But I think what they're describing in that case report that Era mentioned is a refractory. So TTP is bad as it is. Refractory TTP, which is plasma exchange, steroids, rituximab, and a platelet count that won't come up and an LDH that's going up, and more importantly, symptoms that are worsening, is a really bad situation. In that situation, there's no question caplacizumab makes sense over not giving it. There's unknown risk to mom, to baby, but when, as Era said, if mom's doing that poorly, we know where that's going to go, and I would use that as well in that refractory situation every time.
Yeah, I think we all agree on that standard really of care for a pregnant patient with an acute episode of TTP would be plasma exchange and steroids. I would use rituximab if the patient is not improving, taking into consideration that I wouldn't see any improvement in at least 2 weeks. And in terms of caplacizumab, I think it would depend on the time of the pregnancy. If we can maybe deliver the baby there and then give the caplacizumab, I don't know. It's a risk, but again, if a patient is not responding, then I would do it probably.
Okay. So when you guys talk about using steroids, is there a specific steroid you would use over the others? So would you use dexamethasone? Would you start with prednisone? What would your preference be?
Usually we use, I think, prednisone 1 milligram per kilo. And then prednisone is a great medication when used in a short period of time. When used in a long period of time, it carries a number of, not only prednisone, but any steroid for that matter, it carries a number of side effects. So we like to do a very short taper. And prednisone is a medication that you can't stop it from the one day to the next. So usually patients are discharged on prednisone. And then when we see them in clinic and they're doing better, their labs are stable, we start doing a fast taper for, in the course of a month, they should be off prednisone, ideally.
Yep. Hey, one quick comment for me from the previous case. It was mentioned before the patient with pregnant thrombocytopenic and ADAM-TS13 deficient. And I talk about to my patients all the time. You have to be careful and know what you're predicting with things. So the ADAM-TS13 activity being low predicts the risk of relapse in the future. If your platelet count's already going down from TTP, we're no longer predicting what's happening. That's likely an acute episode. So a low platelet count from TTP is happening right now. Low ADAM-TS13 activity is helping you might predict in the future. But if it's already low, it's too late. It's already happening. You got to treat it.
So the time to prophylactically treat is prior to the platelets dropping.
Correct. So I've had patients who have wanted to monitor their platelet count once a week. And I understand why they want to do that. But my message to them is if the platelet count is already dropping, there's nothing more to predict. That's already going to happen. And it's going to accelerate quickly, most likely. If you're going to monitor somebody for predicting the risk of relapse, it's the ADAM-TS13 activity that predicts the risk of relapse, but also gives you time to intervene and do something. Once the platelet count is dropping, we're talking about treatment, not prevention.
Okay.
Sorry, that comes up a lot.
That's
it's good.
a very good way to put it.
Yeah. So going back to steroids, what are some of the negative impacts of long-term high-dose steroids, specifically on the liver? This patient's
We don't
asking.
have enough time left in this session and the next one to talk about that.
So you're a fan, is what you're saying.
Oh, no. It's very effective, very dangerous long-term. It's the best way of putting it.
Yeah, you can have a love-hate relationship with prednisone, right? Because it's very effective, but the least I would say is never ending probably of side effects when used long-term.
I'm not aware of any I'm not aware of any obvious or common liver abnormalities. Maybe
I mean, if anything, I guess it causes weight gain, hypertension, diabetes, and taken together, these things can contribute to fatty change in the liver. I guess of an indirect side effect, but certainly not.
Osteoporosis, mental health issues, irritability, relationship difficulties. It really is effective in the short term, but long term they are an accident waiting to happen, unfortunately.
All right. So this question is about caplacizumab. and whether you think it should be used without plasma exchange. So do you think that's where we're going? Would you do that now?
The sharp bunch.
Yeah. If there, if that would be an effective way to use it or not. If a patient, basically the patient doesn't want to have to go in the hospital and get a line, can they just use Cataland and be fine?
That would be the ideal world, right? I mean, we would all love to, at some point, be able to treat an episode of acute TTP without having to admit a patient to the hospital, put a central line, and start plasma exchange. And hopefully, maybe one day we'll get there. I think that right now, there's not an indication to do that. We certainly, when there's an acute episode, we start the three things together, meaning steroids, plasma exchange, and Cataland. I think that there's been, Dr. Cataland has had really good experience by doing Cataland when a patient is sort of about to relapse, or when a relapse is diagnosed very early.
Very early, yeah.
Patient with a history of TTP. And those are the cases that are helping us set up the case to use just Cataland by itself. I think there's been case reports also in patients that are Jehovah's Witness and they won't take blood products, including plasma exchange. So in those patients, we've used Cataland and steroids and have been very successful.
Yeah, the fairly large series in Germany as well, with early as well as more acute and more severe patients. It's the idea, it's where we think we're all headed, and there should be a study, I believe, starting within the next 6 months to look at that exact question. Can you do this safely without plasma exchange? So it's an interesting question.
Yeah. And just to circle back to steroids for a second, what do you constitute as long-term use? And if you only use them for a short period of time, are you still at the same risk as the long-term use? And once you discontinue steroids, do the side effects reduce? Like, essentially, are you still going to be at risk for those side effects that we stated?
The problem is that I think that we have to look at every patient individually, because, for example, if you have a patient that has a diagnosis of diabetes and then you have to start steroids, his blood sugar is going to go through the roof, so we have to increase the insulin requirement. Maybe he wasn't on insulin before and we have to put him on insulin while he's on steroids. Once you stop the prednisone, in a matter of weeks or days to weeks, that the blood sugar should go back to normal. And the same case with hypertension. But I would say that if used for a month, the patients are really well, but more than that, we try to avoid it.
Yeah, that's in general what we try to do. We try to have them stop within 30 days of their last from when they're discharged from the hospital. So within a month of being discharged, we'd like to have patients off the steroids.
Yeah, so I guess to your question, it may worsen prior medical problems that the patient has. And it should get better after stopping. But sometimes when they were on prednisone, maybe they gain weight. So it's a process. It's not like you stop prednisone one day and the next day everything is back to normal.
And in general, the Rituximab is doing something similar to the prednisone. So think about the Rituximab as the long-term treatment to keep those antibodies down, as opposed to prednisone might be effective indefinitely long-term, but there's no question the side effects will cause much more problem than the TTP will. So it's just not done.
Okay. Well, here is an interesting question, and one I haven't heard brought up before, actually. In a recent study published in the American Journal of Hematology entitled MACE and Survivors of ITTP, and the author's name I am unable to pronounce, but I can pull it up if you're of question. It talks about patients having major adverse cardiovascular events while in remission, with the most common being stroke, and occurring the MACE, or the major adverse cardiovascular event, occurring at an earlier age in TTP survivors compared to the general population. It stated that TTP survivors have a high rate of early onset MACE, and therefore optimization of cardiovascular risk factors is warranted, and that the remission of MCS13 activity was not significantly associated with MACE. So it's recommended essentially that TTP patients have a higher risk of these cardiovascular events. Do you guys want to speak to this? Is cardiovascular health something that TTP patients should be extra aware of and looking out for, or how would you handle that?
I can do this. This is actually work from one of our consortium members, Shri Chaturvedi at Johns Hopkins, and she's done some work with my hematologist, my fellow Senthil Sukumar, and I think this is the follow-up work that she did with Dr. Brodsky. It's Robert Brodsky's son, looking at these complications and why they're occurring. And this is what we were referring to earlier. Stroke seem to be a bigger issue than heart disease. The ADAM TS13 activity didn't absolutely predict who got into trouble. They weren't directly tied, but there also weren't a ton of measurements. So I think it calls the attention to that these strokes and heart disease are an issue for some patients long term, and to do the best things you can to minimize other risk factors, which is smoking, hypercholesterolemia, controlling the blood pressure, while we learn more why they're occurring and how we can maybe prevent those. Those seem to be the biggest issues for patients long term in terms of leading to shortened lifespan. It's less so these acute episodes. It seems to be more so in some patients, these strokes, heart disease, and things like that.
Okay, so
Somebody's
would you
doing
send
their
your,
homework.
yeah, would you send your TTP patients to a cardiovascular or to a cardiologist?
Definitely,
Yeah.
I think that it depends on the patient's other medical problems. Every patient with TTP has to have a primary care physician. Ideally, I think someone that is not a medicine doctor, but someone familiar with the diagnosis of TTP, and probably, you know, he or she will refer them to a cardiologist if they think it's needed.
Probably makes sense to help manage it. It also, you have to ask the right question when you send a patient to a physician. So what you want to ask the cardiologist about is doing things to minimize the risk factors for cardiovascular disease and stroke in the context of TTP, which may have an increased risk for those.
Okay. So if the patient has an ADAMTS13 that is deficient for almost a year, no other symptoms of hemolysis, no low platelets, nothing like that, does that guarantee that the patient's going to relapse? And if so, and if not, how would you monitor the patient to ensure that you didn't miss an impending relapse?
I think it's not a question of if, it's going to be a question of when. And it is, what are those second hits, those third hits? You know, well, if we use the patients with congenital TTP as an example, they're not in a constant state of TTP, but we know that eventually it's going to happen. Obviously, big events like pregnancy, surgeries, infections, critical illness would all worry the heck out of me that those would be just that final thing that's needed to send that person over the edge. And like Dr. Cataland said before, if you're going to hurry up and wait until the platelet count drops, then you're not preventing it anymore. Then you're actively treating a thrombotic microangiopathy. And when we think about what that means, that there are clots that are occurring in the vasculature, I don't know if I would feel comfortable just watching it, especially what we know nowadays, that, you know, a course of Rituximab versus putting someone in the hospital with a central line and plasma exchange just because we're catching it early. To me, that's not the better part of discretion. You know, and if you're going to have to check platelet counts every week, at that point we've already missed the boat. You might as well just start the treatment for it. If you're going to come in every week for platelet counts, you might as well come in every week and get a Rituximab infusion.
Yeah, I think this is something that we're trying to study. Who's going to relapse, right? We know maybe almost half of the patients will have a relapse, and we know that we need something else beyond the ADAMTS13 activity. And it's true that Rituximab for the majority of patients is very effective at increasing the ADAMTS13 activity and preventing relapses. but not for everyone, and not everyone needs it. So we're trying to figure out what other biomarkers, in the same way as we check the ADAMTS13 activity periodically. Is it something else that we can check that is going to lead us towards, oh, this patient has a deficient ADAMTS13 activity, but yet he's not going to relapse. So we can just watch him versus treat. But we don't have many answers yet.
Yeah, we're looking. So I mean, there are patients, we used to say multiple relapses and undetectable ADAMTS13, they should be treated. As Ara pointed out, if you've got a history of TTP and undetectable, most people would lean toward treating them. Where it gets a bit tricky is the patient had TTP, got rituximab, and a small subset won't respond to it. If you don't respond to it and you're undetectable after rituximab, it certainly might make sense to continue treating to prevent, but the next treatments may have some more side effects. So it gets a bit more nuanced and difficult to know exactly what to do, because the side effects start to go up after you get past rituximab with multiple agents.
Warning signs or symptoms other than low platelets for a low ADAMTS13? Is there anything symptomatically that a person may be able to observe?
Well, remember, the low activity, we're not aware of any symptoms people have from just the low activity. But things that might be early signs of your relapse could be abdominal pain, nausea, kind of more subtle things that people might pick up. But again, once you're getting symptoms from that, it's not prevention any longer, it's treatment. But we're not aware, and correct me if I'm wrong, guys, I don't think it's ever been shown undetectable activity alone has given somebody symptoms.
No, and as Claire mentioned, right, the long-term complications that we're seeing in patients with TTP, high risk of heart disease and stroke, are not related with the ADAMTS13 activity at relapse. So I'm sorry, after, on follow-up.
I would say, I just want to jump, like I've had quite a few patients who've been able to predict it, that something is wrong, something feels off. And I would encourage, the TTP patients out there, especially if you still have undetectable ADAMTS13, still have an inhibitor. If something feels off, don't poo-poo it. Don't, I mean, it's a simple CBC that can let us know one way or another. But I don't know what it is, but many of my patients have been able to just feel that something's off, and that has been, and we've caught them early in their actual relapse.
Okay, and is there anything that TTP patients should avoid taking or eating that they shouldn't have just because they're a TTP patient? This the question specifically inquires about ivermectin or grapefruit, but those are pretty specific. So just in general, are there dietary or medical restrictions that you should have just because you have TTP?
I think that ivermectin is probably brought up because it was it has become more famous than it ever intended to be, I think, because someone suggested it's prevented COVID infection, which it doesn't.
If you're a St. Bernard, maybe you should be taking ivermectin, but otherwise, I think you should be careful with it.
Yes, but taken together, I would say that what I tell all my patients is try to live a healthy life. Everything that your primary care doctor suggests about eating healthy, maintaining a healthy weight is important also with our patients with TTP.
Along those lines, I'd like to sort of, again, advocate that this comes up with my TTP patients, where we get questions like, my doctor wants to do this, they want to do this, but I had TTP. I mean, unless someone is in the active throes of active TTP, the fact that someone had it should not limit you from getting the standard of care. If you need a catheterization, you need a biopsy, they want to start you on this thyroid medication, this blood pressure medication, this diabetes medications, get it. I am unaware of any clinically available medication that will give someone TTP. And if anything, having TTP with uncontrolled diabetes or uncontrolled high blood pressure is even worse. So just because you had it, I would say this is part of your past medical history, not your current history.
Yes, and on those lines, we talked briefly about if a patient with a history of TTP should get the COVID vaccine, and we said yes, but I want to also reinforce that you should be getting all your needed vaccines, your yearly flu shot and pneumococcal vaccine after 65 years old, and tetanus vaccine, and everything else that your primary care physician recommends. I think the idea is we want to prevent any other illness in our population with TTP so that they don't get a TTP episode.
All right. Well, on that note, I just want to thank you guys for joining us. Obviously, another great session. I know there's many people that appreciated it. If for whatever reason, anyone viewing your question wasn't answered, send it through to admin, ADMIN, at USTMAconsortium.com, and we'll send it through to our medical board and try and help you the best we can with an answer. So thank you everybody for joining. We appreciate it.